Good morning. My name is Gail Knutson. I'd like to welcome you to our advanced medical course. We have most of our faculty here except for Dr. Longani because he's teaching in the surgery course. So maybe I can just get our faculty to stand up as I introduce them. Dr. Josh Safer, and he's an endocrinologist and chief of the Transgender Health program at Mount Sinai and an incoming board member of WPATH. Jenna, do you want to stand up? Dr. Jennifer Slovis, and she's the transgender care director at Kaiser in San Francisco. And she's a family medicine doctor. Dr. Michael Erwig, and he's an endocrinologist, and he's in charge of the Transgender Health program, one of the programs at Harvard. Dr. Erica Sullivan, and Dr. Erica Sullivan is a primary care director, and she is at the University of Utah. And Dr. Asa Radix, who is an internal medicine specialist and from Callan Lord and also New York University. And so you should have received or will receive today a copy of all of the slides for this program. They are going to be released to you today. And also, if you have not already seen, the Standards of Care was released yesterday. And so what we will be doing in between the breaks is putting up the recommendations from the Standards of Care, just as a summary document. So it was released yesterday, and Asa is one of the co-chairs, and is that right? 254 pages? Yeah. Okay. Yeah. I'd just like to start and tell you a bit about what we're going to be doing today. So I'm going to introduce the course as I am now. I'm going to do just a very brief overview of mental health and how it relates to advanced medical. Dr. Safer is going to do a talk on hormone therapy, and then we're going to do complicated case studies, and that will be with Drs. Erwig, Safer, and Radix. We're going to have a break, and then complicated case studies again, lunch, and then we're going to have a surgery talk by Dr. Longani, who is one of the surgeons at GRS Montreal here. And then we're going to do advanced primary care talk with Dr. Jennifer Slovis, and then primary care case studies with Dr. Deutsch, Dr. Slovis, and Dr. Anderson, and then some complicated case studies related to surgery, and we'll end around 4:30 today. So welcome, and I hope that you enjoy our course. Can I have the next slide deck, please? Great. So I've been working in transgender health now probably for 25 years, and most of the work that I have done is in the work of sexual medicine and transgender health. My background is in psychiatry, and I've actually never worked in psychiatry. I've only worked in sexual medicine and trans health. So, and I worked in sexual medicine center at the University of British Columbia. So when I talk about mental health considerations, they're more in line with people going to have surgery, people going to have hormones, and also ways in which to help people access surgery. I encourage you to take our mental health, advanced mental health courses if you're interested and would like to broaden your knowledge and understanding in that area. And that's also one of the courses that we offer. So when we have done these courses in the past, and like the different questions that people ask. These are the top 7 questions that people ask related to mental health. People preparing people for hormones, preparing people for surgery. And one of the questions is, does initiating gender-affirming hormone therapy during a psychotic episode or a manic episode worsen mental health? And so so how we kind of approach that is that the person does not have capacity in these acute states to start hormone therapy. So it's a bit different, though, when people that are on the schizophrenia spectrum, whereas when they have a long-term illness, in many cases, following them for a long period of time, and well known to the team, they do have a capacity to consent for treatment, for hormones, for surgery, and of course it's depending case by case. So there was a really good case study that was a case series that was done by the Dutch group, and they looked at people that had a diagnosis in the schizophrenia spectrum, and they all had undergone gender-affirming treatment, and they had a 3-year follow-up. And so I think this is a really good case series that talks about, how to follow people to ensure that they have the best care possible and what kind of recommendations they have in place. So, for example, consider admission to a psychiatric ward unit instead of a surgical ward for extra psychological assistance, like post-operatively after a person has had surgery and is stable. So it's actually putting a lot of wraparound care in place in order to be able for people to access care. And so this comes down to one of the recommendations, and there are a few recommendations in terms of the assessment chapter in terms of capacity. And so people that are assessing people, like in terms of writing letters, they should be able to assess capacity to consent for treatment. And also this is the same recommendation you'll see in 5.3, so capacity to consent. Also, there are more capacity recommendations within mental health, and this has to do with starting treatment, being involved in perioperative care, that they're able to have a plan in place, and also that there's people that are supporting them. And also we'll talk a bit now about in a few slides, about substances. Another question that was asked in terms of the mental health chapter was, does gender-affirming hormone therapy decrease anxiety and depression? And it may alleviate depressive and anxiety symptomatology. And this was a really interesting meta-analysis that they did actually for the standards of care. And what they found was that when you looked at these different studies, that the strength of significance was low. And it had to do with how the studies were set up, how many people were in the studies, how everything was measured. So it's not to say that, because we all know in this audience that people have a better quality of life, depressive symptoms decrease, anxiety decreases. But what we're trying to do is, for the researchers, is really develop much more robust research protocols so that it's much more measurable. And this was a really nice study that came out from John Arcelis's group not too long ago, and it was just after this was published. the meta-analysis was published. And they did, it was one of the first longitudinal studies that was 18 months, and it looked at the effect of gender-affirming hormone therapy on anxiety and depression. And so what they found that symptomatology was significantly decreased for depression, but not non-significantly reduced for anxiety. There was a trend downwards, but not significant. But there are many other factors that, play into anxiety, as we all know. This is another important study that came out from Justine Dufresne, and they looked at they looked at depression, at aggression. And so looking at this, what they did is they measured people that were on hormones, and they were saying like 12 months of testosterone therapy, also estrogen therapy. And what they found is that there was not a change in terms of aggression. But what I think that was interesting is when they looked at this, other psychological or social factors such as anxiety were related to like self-reported aggression. But the hormones themselves did not cause this change not cause a change in this aggression. And I think that's really important because people always ask us that. Tobacco and effect of surgery on surgical outcomes, and I think all the physicians here can say that, and also non-physicians, that tobacco really affects surgical outcomes in many different ways. And this was a good paper that came out, and it's through the WHO on tobacco and post-surgical outcomes. And I think that not only is tobacco affecting, the anesthesia, but it's also very much affecting wound healing. And you'll hear later, and as we go on through the day, that tobacco is, or tobacco smoking is not acceptable in terms of people having surgeries. So when you're, yeah? Mm-hmm.
I was just going to ask, I get asked quite frequently, is it really the tobacco that's the problem, or is it the nicotine? Because, now people are vaping and they think it's so much better.
Well, it's the nicotine that's related. Like, does anyone want to say anything else, or Asa or Erica? Mm-hmm. 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 And then, but if you look at that, and then we look at the next part is about cannabis. And cannabis is very interesting in that there aren't a lot of studies on it, and they're still continuing to have studies going on around that. Is that this goes back to the smoking part. It's not okay in terms of the smoking and how it affects your lungs, and also in terms of healing, like, there's not a lot of data on it. So does anyone want to comment from our panel about that, or Josh?
No, I think the question mark is the key point there. But like you said, smoking, whatever you're ingesting, is not going to be good for your lungs. The substance may be technically benign.
Does anyone know any other studies or any more recent studies that have been done about cannabis? So it'll be interesting to ask Alex when he comes this afternoon what their protocols are at GRS Montreal around smoking, and what his experience is in working in other centers, because he's worked in other centers in the U.S. and also in Europe.
Yeah, what about the edible?
Oh, that's a good question. So, Janet, do you want to answer that?
We tell people just to switch
Yeah.
most people are eating, but we'll just ask people to switch to edibles.
So that
Yeah.
you find to be tolerable.
Fine is too strong a word. So
Better than
Yeah.
smoking.
it's that fine, yeah, so we don't, the short of it is that gets into a space we don't know. We're pretty good
Yeah.
with smoking being bad. We're pretty good with nicotine being bad. But when you do neither, which is what an edible is, then it kind of is an unknown. It's not that we know it's okay, that's not one of the two things that we do know to be bad.
Yeah, so what most people will say, as Jenna was saying, is if you're smoking cannabis and you do not want to quit, like taking cannabis, then you switch to the edibles. Mm-hmm.
Gynecological, like a hysterectomy perspective, I
Yeah.
have a lot of patients who actually say the edibles help with their pain postoperative, which
Ah.
is opiates. It's not coming out. It's being researched complicatedly in the U.S. because of funding. But I let my patients take edibles and
Mm-hmm.
often do better pain control.
Great for pain control.
And
Yeah.
one other thing we can just put out there, and we can discuss it when the surgeon is here too, but seeing as we've like veered off
Yeah.
already,
That's the idea, to be interactive.
is certainly some surgeons have a little bit of a hierarchy based on blood flow to the area where the
Yeah.
surgery is happening. And so sometimes this is paradoxical to people who wear, in the sense that like vaginoplasty, which is a bigger surgery than let's say a chest reconstruction surgery, might be more forgiving because of good blood supply, where a chest reconstruction surgery could be more problematic because of the poor blood supply.
Any quick questions about that? Comments? Yep.
It does affect how much anesthesia they take
Mm-hmm.
by a long shot.
Mm-hmm.
So don't, try to tell them, we need to know
Ah.
how much you're eating, because if you don't, the anesthesiologist is gonna have a harder time keeping you asleep.
Yeah.
That's usually a good motivator to.
Yeah, no, it's great. That's great. Yeah. Yeah. So I'm not sure if did you hear that on the other side of the room? So do you want to talk at the mic there?
So is it on? Can you hear me better? Okay. Anecdotally, I'm okay with patients switching to edibles for their hysterectomies, but they need to tell us how much so that the anesthesiologists know about it and can adjust the amount of anesthesia that they're getting. Otherwise, it's sometimes hard to get them all the way asleep.
Thank you. And it's saying that, that the increased anesthetic dosages, like you were saying, needed to put them all the way asleep, as you were saying. So the next question is post-surgical regret common? And the answer is no. And I think that most people would, agree with this in the room. And it depends on what study that you're looking at. But as you look at the studies, the percentages of regret decrease as the surgery techniques have got better over time, so that the surgery rates of regret are like around 1% or less than 1%, depending. And so, yeah. Mm-hmm. Oh, since going into the 2000s, yeah. So when you look at people that are having regret, it's usually if they have had a poor surgical outcome, if they have, and also if they have really poor social support, also if they have like poor financial support as well. Any questions or comments before I end? And I'm going to ask Josh to come up, and this slide deck will be in your package. And yeah,
Forgive me, I just was wondering if there's any age connection to that regret?
into the regret category.
Because I'm a mental health therapist, and I think about talking with parents who often voice this and maybe enlarge it.
I'll ask. Does anyone know that answer in terms of ASA, maybe related to age and regret?
You know, I haven't, I mean, I've had a few patients
Oh,
express regret after surgery,
mm-hmm.
and they've been all different ages. I mean, the earliest, youngest was a 23-year-old who, after having a hysterectomy, broke out and said, I'm not trans. And,
Mm-hmm.
you know, and that was not, I mean, but actually didn't regret the path to that point, which I think was interesting. And I had another person who was like in their 70s who decided to have a mastectomy after breast estrogen. But, you know, I haven't seen any personally. It's so rare. I don't think we have enough really.
Okay. So Asa was saying that he hasn't seen any correlation. Person in the back there?
Mrs. Coyle, just a quick question. For slides that have data on them, do they have the references?
Yeah.
Oh, great.
Mm-hmm. Were you going to say something? Okay.
I just the only thing that I can think of that's really out there is people who get engaged in care at younger ages, in general, have less mental health morbidity. I think we can see
Mm-hmm.
that.
Yeah.
And so, but being rigorous in terms of where it goes for regret and things like that, I don't know if I want to get too definitive or conclusive, but I think there's a little bit of an element there. I think I've seen studies where, and maybe it's just confounded by that reality, where they think that the younger age crowd is doing better and having less quote unquote regret.
When you say engaged in care, do you mean any kind of care, mental health care, medical care, just general care?
Yeah, I don't think we do a very good job of parsing out. It's not like if you get a surgery or if you get a hormone. It's if you get you know, in care and then it's customized to you. So.
Did you want- Okay. And so, yeah.
An additional question about our patients who use cannabis
Mm-hmm.
in surgery. There's such a variety of ways that people classify or don't their use. Is there anything that's particularly helpful with quantifying their use, like how often you're buying or what have you, if it's not?
Ask them how many, you know.
Do you want to? Can you go to the mic? Sorry.
So I just ask how much they're using, and like, are they having one small thing, or are they like at night to go to sleep, or are they doing it 6 times a day? And you know, the strength is going to vary, especially, you know, in states where it's not, where recreational use isn't legal. Who knows? What's, you know, you don't, it's not like it's quantified.
Does that answer your question? Okay, great. And in terms of the surgery recommendation around regret, is that if people have regret that related to surgery, that the person is seen to receive the best care in terms of multidisciplinary team, like the surgeon, the primary care person, primary care physician, the mental health physician, so mental health professional, so they can receive the best care possible. So the key takeaways, that it's really important for people to have family support as they're going through a surgical transition, social support, that they have as many community connections as they are able and are willing to have, that they have physical self-care, like they're eating well, exercising, no substance use or reduced use, in terms of mental self-care, talking with loved ones, meditation, different healthy coping skills like exercise or talking. So, and also, this is part of the pre-op and post-op plan that people will be, that people need to be engaged in terms to have the best possible outcomes in all these different domains, physical, mental, spiritual. And we're going to talk more about those, the pre-op and post-op planning in primary care, and we're also going to talk a bit more about that in the surgery portion of the day. So there's some references. You're asking about those, and they're included in your slide decks when they come out, so that you can see these different, so you can see the different. Papers that are associated with it. So thanks so much. I'll turn it over to Dr. Safer, and he is going to do a lecture on advanced hormone therapy, and I will be back shortly with you. So thank you.
All right, good morning. This is the good morning for the people whose day starts at 9, and later we'll have a good morning for the people whose day starts at 11. So, I'm Josh Safer. I'm an endocrinologist, and I'm in charge of the program at Mount Sinai. And I want to as we shift a little gears to hormones, I just want to get a little sense of who's in the room. So by specialty, at least. So we'll maybe just go down the line with some of the classic ones, and then we'll see who else is here. So primary care providers. That's the room. Okay, good. And endocrinologists. All right, some friends. All right, and then infectious disease folks. And then mental health folks, and surgeons. Okay, well that was going to be my next group, so there we go. Super. Any other GYN? That was okay. Perfect. Okay, and yes. So who am I missing? Adolescent medicine. Oh yeah, of course. Other peds or adolescent medicine. Perfect. Okay, good. All right, this is very orienting. Thank you. All right, so what for a lot of the day, I want to go over the concept of the rest of the day. The concept is to have is the expectation is most of us are doing care, and therefore it's not always the case that the people who are up at the front doing the talking are the how shall I put this are the bottom line. Sometimes it will be others in the crowd, and so and a lot of what I think we get out of this is hearing each other's strategies and how things are working. So as you saw from the schedule, it's heavily case-based. We have a couple of situations to try to get us on the same page, more or less. So that's my job right now when I talk about hormones a little bit. And then we go into some cases and really hash it out a little bit. What are we really doing and what do we think? And then in a parallel reality for the primary care elements, and then there's a peri-op element to that, or at least to the cases, and similarly toward the end, kind of in a focused way, where Alex will show up and review surgical techniques and such, trying to get us all up to speed as far as that all goes, and then a little bit back to what are some of the specifics that we're really dealing with, because many of us will have seen that already. So let me dive right into things here. So yeah, no financial disclosures about this one currently, but always open.
For registration was like crazy, so if there's space in the middle, can we maybe like move in so people can join?
Yeah, that's perfect, whatever. And there's some spaces up at the front here. Good. All right, and it's not like a line out the door, right? I can talk, right? Okay, fine. All right. So yeah, so the objective here, it's ostensibly to understand current approaches, but really my goal here is to go through things pretty quickly and just make sure we're all kind of on the same page. So I'll say a few things, and if that helps, then great. And if people want to criticize, they can. And the group of us who are here today as the faculty have a variety of different views from endocrine and primary care. And so we'll interact with each other too a little bit and not even always agree. So in very, very broad strokes, what we're doing, or what I need to emphasize to folks, is it's not this yin yang of estrogen versus testosterone, but rather it's pretty much a testosterone story of moving testosterone up and down and thinking about what testosterone does to various elements in the body. And what exposure to testosterone over certain amounts of time does. And so the cartoon here is really just to accentuate that point, that very, very broadly speaking, to the degree that estradiol is a reasonable surrogate for estrogen, adult humans have fairly similar levels. It's that tenfold difference, at least using total testosterone as a measure, because that's all we can do reproducibly, at least in at a clinical level, where there's that tenfold greater testosterone in what we think of as typically male versus what we think of as typically female. And then specifically, what we're doing is we're manipulating things. Oh yeah, one other piece here is what I said before, is thinking about too the impact of hormones, and heavily it's the impact of androgens. And this is just a picture of Tanner stages, and I'm not going through Tanner stages particularly. But the agenda, when we're thinking, especially when we're thinking of opportunities to intervene, are again the impact of androgen and what may or may not be addressed depending upon when somebody comes into care relative to when they might have preferred to come into care, and that kind of cuts both ways in terms of features that are androgen specific and let's say breast development, where you need some estrogen in order to have breast development. That is, if you don't have estrogen receptors and you don't have estrogen, then you don't have breast development. But on the other hand, if you have whatever that is, some threshold of estrogen in your system, then breast development ends up being very dependent on how low your testosterone level is. So that development occurs in the absence of significant testosterone. But people with those same levels of estrogen but higher levels of testosterone don't have breast development, and therefore we're dealing with that when we're thinking strategically in terms of treatments. Okay, so I'm calling. Basically I'm labeling these things by what we're trying to do. And so masculizing gender-affirming hormone dosing, kind of the beginning here. And bottom line is we're using testosterone. Our patients tend to, at least in the United States, tend to look for injectables because that's what they hear they're supposed to receive. I'll tell you, as an endocrinologist, I love injectables because I know they're actually getting the dose. And we're all kind of at a level right now where weekly subcutaneous dosing seems to be a nice cadence for most folks. But there's no health reason why you have to pick that particularly. That is, if somebody got trained to do intramuscular or receives it that way, there's nothing wrong with that. And the larger doses with greater periodicity, I think, are less comfortable for the patients often. But I have patients where they don't like needles. The customization here ends up being very patient specific, and I wouldn't argue that it's a health thing that we're discussing. The gels are super popular among non-trans people because that's what they all read is what they're supposed to be doing. As an endocrinologist, I actually still like the injections because the gels are very inefficient, and that all their pitfalls are related to that. which is that you need to put more medication in the gel in order to compensate for their relative inefficiency in transfer. And so that's that whole concern about accidentally getting some of the product on friends and neighbors. And that also is the reason why I like it less. That is, especially larger individuals have a harder time getting doses that they like with the gel products that are out there. You would think that a patch would protect you in some way because it would hold more against your body. Patch actually came first in terms of development of drug products, and the reason why it's not popular is because for whatever reason these testosterone patches itch. I think anyone who's tried to prescribe these has had bad experiences and knows what I'm talking about. I think I have 0 people using patches right now. I had one, but I think that person is no longer on patches. And there are a couple of other products out there, and then depending upon in what environment you operate, money can play a role, although over time that plays less and less of a role as we mainstream care in our various systems around the world. And the bottom, and the testosterone are long acting, so a little emphasis on titrating quickly to the goal testosterone level, or your best guess, I would call it. So for adults, I'm just going right there, and I emphasize this because for reasons unclear to me, and we're not going to talk about peds a whole heck of a lot right now, except kind of tangentially, but in the pediatric world, it is standard to titrate up hormone doses for people who have who need hormone products for whatever reason, and that comes from a concept of simulating a typical puberty. And I don't know that we know, though, that there's any health reason to do that. And, it's like a lot of things in endocrinology, it's just out there. So, I used to be a thyroid person, actually, and there was a lot of talk about using T4 and T3 because that's what your thyroid actually produces. But we've kind of settled back into just doing T4 and you're letting your body do the converting as necessary. To me, it's like it fits in that kind of category of things that people do because it seemed like it was physiologic, but we don't have data to argue in favor of that and observe that at the adult level, we're not doing that even because the agent is so dang long acting anyway. It takes weeks and weeks and weeks to get your levels. And then the only other little point for me personally is that I start at about a half of the dose that is out there in the literature for a typical quote-unquote male testosterone dose, where for an injectable it would be 100 milligrams a week, and I'm giving a lot of my trans masculine people 50 milligrams a week, and then maybe bumping it up a little bit. And my only thought in that space is many of them have gone through or partway through a pretty typical female puberty, and they're literally smaller people, and that's maybe the whole dang story. And then the goals are not, the goals, notice the window is broad, and that's actually a really important point too. And you'll see different normal ranges out there in different, from different places, and I would not get too hung up on that. In fact, as we were freshening up these slides, because actually, I forgot to also say, oh my God, we're in person. But the last time we were doing this was 2019. And so we were freshening up the slides with that. And actually, a huge thank you to Erica. She's the artist. But the point, so we were looking at some of these normal ranges, and the point is there are no data for it, and actually we're looking at total testosterone with a lot of binding protein influence, and to overthink it is just going to torture the patient. And we can get into some of that when we do some of the cases. All right, so in terms of monitoring, yeah?
Sorry, what for you is titrating quickly? Like, what's your typical interval with people?
Okay, so what is for me titrating quickly? I guess the dose I want to give the patient and I start them on it. Okay. So All right. So so in terms of what we're following is it's really it's the hematocrit. The only data in terms of treating people with androgens come from the hematology literature, where with polycythemia vera they have more events with people with hematocrit greater than 55%. Those are the data. Then it's two degrees of separation here, where the cisgender testosterone crowd in the endocrine society look at those data and say, well, if it's an active commission, let's give ourselves a buffer and let's go with a 50% hematocrit. When we're given androgens, in order to feel safe that we're not going to be precipitating events among our patients, and we who are taking care of trans people are simply following that exact logic pattern, and that's the entire story. But we do keep an eye on that, and the only thing we could discuss it when we get to cases too, is how frequently you need to pay attention to these things and how stable is stable, and we can get to that too. Yes.
How do you marry the patient who is really unwilling to reduce their testosterone because of polycythemia? So if you have that hematocrit greater than 50 and they're really reluctant to reduce their dose?
So I think we'll get into that with cases too. Yeah, because right, you can envision all sorts of thoughts. Like, we are kind of gatekeepers here, despite that having become a dirty word. So we are the prescribers, and we're the advisors, and we can go into where in that interaction with our patient we go, right, in terms of trying to keep them healthy, and not overanalyzing it ourselves, also, in terms of what is dangerous, et cetera. And we'll get into that. Yeah.
Can you explain just the logic behind worrying about hemoglobin if basically the whole point is just to get in the normal physiologic male testosterone range, right? So we don't worry about high hemoglobin levels in cisgender men with normal testosterone levels. So can you explain a little bit
Yeah, so
why we would worry about that when the testosterone is being given as an injection instead of being effective?
Right. So the question is, if we're just aiming for physiology, why are we worrying? And the short answer is, we do care for cisgender men when we are giving them testosterone. We use the same guidelines, and for people who have the testosterone naturally from their testes, we actually still care. Like when you screen, and if you have a hematocrit of 55%, you're going to bring hematology into the picture and try to figure out why that's so, and intervene and actually treat them to get that down if you can. So we do care, and it's the same logic pattern. All right. And then other items that you see on various lists of things that you should be monitoring, if you think about it, are really primary care needs. These are not specific to trans people. And so that's another thing we'll need to talk about maybe, or reinforce, is good health is good health, and we should be practicing that, or good health care, I guess, but we should be careful not to, and that's actually a huge component of primary care, is what is good primary care, as opposed to saying, oh, trans people need this specific thing, or that where I'm particularly worried about a trans person's A1C, versus just I should be keeping track of everybody and making them exercise. And then and variation on theme, routine screening. Right now, we don't have specific data for trans people necessarily, and so we're basically looking at organs present. And again, we'll get into that a little more in the primary care space, but that's a global theme. All right, so the supplementation typically for across the male spectrum, cis and trans, and is simply androgens for life, for good bone health. And switching gears now, again, just I want to go through the feminizing pieces. Yes, sorry.
Sorry, I apologize. I have not read the whole new Standards of Care 8 yet, but are there benefits from the screening to start then?
What we're doing is we are, so I guess we're a little less, actually it's a good question because I'm on both primary care and hormones, and now I have to go back and look and see where we say it. But the concept is we're doing what is right for good health, like we would do for any of our patients. And I have to go look at how we phrase that. But that's the concept.
I'm checking it, but it's kind of silly when the kid's 13.
Yes, kind of silly when the kid's 13, just for those who didn't hear. So again, we'll go back to on the cases there, but the point you're making, I think, is very much in theme with where the new SOC is what makes sense. Yes.
Yeah, just a question. I'm not sure if it belongs to you. I'm gonna go for it. Wondering if there's any thought. I know you haven't talked about blockers. I know this isn't pediatric centered, but in terms of executive functioning, when I'm having a lot of questions from parents about brain development and age 13, and their child's been on blockers for 2 years, and they're worried about executive functioning, skill building,
Right. So I would characterize that as far outside scope for this. But we'll talk about that in cases a little bit, and I won't just blow it off. I will say that puberty blockers, GnRH agonists, are safe in other contexts. When we use them for precocious puberty, we're not seeing that or worrying about it. And so I just don't want to, it's another situation where it's almost like people are intentionally throwing up roadblocks here and bringing up concerns while ignoring other populations where we're using the same medication. So I'm not overly anxious, I guess. Okay? Yes.
Can you speculate on if there's some minimum dose or level of testosterone, kind of for lifelong maintenance for patients who don't desire full maximal masculinization for bone health and other long-term health outcomes?
And so the question is a minimum testosterone dose that you have to have circulating for minimal, let's say, bone health? That's what it is? And the answer is, great question. No, I haven't. I have no, and again, we'll see if my other co-panelists have thoughts in that space as we get to that. Anyone want to say anything differently quickly?
So I mean, testosterone gets converted into estrogen. So there are some studies that look at below what level of estrogen you could get an increased rate of hip fracture or osteoporosis. So that's just one consideration of it. But I think one of the important things about testosterone is that it acts in different tissues in different ways. So it may have a greater, so if you give a standard dose, it may have an effect on one organ, but not on another. So it may have an effect on hair or voice, but not on menses, for example. So there's a lot of individual variability how people react to it.
And I think it would matter if you had ovaries or not.
Right.
I mean, my thought would be if you didn't have ovaries, I'm going to be paying more attention to it than if you do have ovaries. Because if you have ovaries, then they're going to be helping if we're not giving you enough testosterone to make sure bone health is adequate. But if you don't have ovaries and you're not having any exogenous hormone, we probably have to pay more attention.
Yeah, I think that's actually probably the biggest point, which is still a we don't know, but except Michael is telling you ways that maybe we could know eventually. But right, how much endogenous hormone you have. Obviously, if you're on some continuum, that's more relaxed than if everything's coming exogenously. Yes.
I often ask people to ask if they're going to get more effects if their level is 700 rather than 500. And I usually say you're getting the effects from the testosterone you would expect. I don't know that there's a difference. But do we know if there's more effects at a higher level than a lower level within range?
What we know in the cisgender world is within the normal range that we can't determine differences. So that part's true. But what I can further say, and I think many of us have this kind of experience, is let's say when you're starting out a young person and trying to get menstrual periods to end, that you might choose a number, like I said, and go right there, and then their periods are still there, and you have to tweak it up a bit within the normal range. So obviously you made a difference. So I guess we've all had that experience, and I'll just leave it at that. Yeah.
Well, in my short experience with adolescents, it's not only the dose of testosterone, but also the time of exposure.
Yep.
That takes that dictates the changes that there are.
Exactly. Time of exposure, huge. I mean, look at people across a lifetime of exposure and all the characteristics and things that get accumulated, for sure. Yes? is there a so so the short of it for me in that space is there a point, like, am I worried with a 900 with that range? And I guess from a data perspective, there aren't a lot of data within the normal range and a little bit outside the normal range, frankly, too. The data I go back to the hematocrit data, and things like that are really what we're looking at in terms of harms, and otherwise testosterone's pretty benign. So, all right, yes?
Is there any information about facial acne? If you go up more quickly on testosterone or more slowly, does that have any benefit?
I'm not aware of any data, Michael, with regard to, do you have, or any of you have data with acne correlation with?
I think that with the higher dose of testosterone, you are going to see more greater effects. So there's going to be more likelihood that the blood pressure is going to go up more, that the hematocrit's going to go up more, that the acne is going to be worse, that the HDL is going to be suppressed more. So I'm a little bit more on the conservative side. So I basically see that the average cisgender man has a total testosterone of around 500. So I wouldn't be comfortable having a trans man running at like 900, which would be a super kind of physiologic, because they may not be getting any additional benefits from it. If they're getting all of the effects when their testosterone level is at 400 or 500, why run them at 900 where they could have potentially increased cardiovascular effects, high blood pressure, etc.? So my approach is generally to kind of treat with a minimum dose to have their effects while trying to minimize potential adverse effects.
Yeah, and we may actually disagree a little bit there, and so we'll come to that. But I think that concept, and for medication in general, right, is you give it the minimum medication that does what you need it to do, right?
But, ask your patient, right? Because a lot of folks, even on low doses, sometimes people are like, whoa, I just got a full beard. Whoa, this is too much. Like, if you go up. Other people, they're running higher, and they're like, I feel stalled. I'm not seeing much. Do we have room to go up a little bit? So you can watch your hematocrit. I always repeat hematocrit and make sure they haven't fasted, because everybody thinks you need to fast when you go do these testosterones. And when you repeat it, if they've drunk a lot of water and eaten, a lot of times that hematocrit corrects, by the way.
Yeah. And I think we'll rehash some of this again in cases, because you can hear we're going to have some slightly different viewpoints there, and just some different things to consider with your patient. Sorry.
Skin issues, it's really a good idea to talk with people about what regimens they're using, because they may not have ever had acne before, and so they don't know about topical benzoyl peroxide and so you should be having that conversation with, anticipate you're going to have some acne, let's talk about what your skin regimen is.
Good. Okay. So it says we're going to switch to feminizing hormones, and that's the 920 spot. The people who wake up at 9:20 are here, and so let's come in and take a seat. do make yourself comfortable, and we have plenty of seats in the middle, and there's some up in the front, and don't be shy and don't think you're interrupting, because it's all interactive anyway. Yes. So it's we mostly these are very American-centric slides. It's a good point you make, but I can tell. But quick math correction here. So let's see. So about. I was going to say 10 to 30. I was going to make it even easier. But I'm 70 and 20 for temperature. Hey. So anyway, so so it's basically 1.7 and 50. So when we say 50 for testosterone for like the upper limit for a typically feminine, that's a 1.7 for you for nanomole per liter. And you were saying 10 and 34. Yeah, that makes good sense. So bottom range for men is going to typically male is going to be like, what do we say? So we like 250, 275, 300, and you're going to be talking 7.5 to 10. Oh, and 34. I got it. That's the upper limit. Sorry, I'm a little. I only wake up at about 10, by the way. No, we're doing exactly the same. The only thing I'll say is that because that nuance was we were talking about like 700 versus 1,000, and the point being we're a little liberal, and so you're going to have a variation on theme in the 30s there, where don't get overly caught up because your lab says, oh, 33 is important, or whatever your cutoff happens to be. It's the same it's going to be that same, something in the 30s. Sure. Okay, so whoops, got a lot of myself there. Okay, so feminizing. Let's go to feminizing just a little bit. Right, so like I was already saying, strategically, what we're doing is we're really taking testosterone down. And I know our patients think it this way, and some of our colleagues think it this way, and we have to kind of help focus because I don't know, I'm a concept person, and so I do better when I think of what I'm conceptually doing. I'm not trying to blast somebody with estrogens. I'm using estrogen as a tool to achieve a certain thing with androgens. If this person has testes there, if if they don't have testes, then it's still in endocrine, we're still thinking in terms of feedback. And so I'm looking for bases for assessing estrogenization, which might include LH and FSH. That's what we do in general with people who are getting dosed with estrogens, where we don't have a uterus to help us. And I'll come to that a little bit conceptually. But the point is we're manipulating testosterone with these estrogens mostly. Some degree of estrogen supplementation. If we're talking about bone health, right, there's a range. And I think there's a bit of a conversation we're going to have here, too. Because I think in the cisgender world, for people who don't have a uterus, we sometimes underdose people. And so if we simply translate that to our trans feminine people, we're going to get into some of that same trouble, and we want to make sure not to do that. And in fact, frankly, there probably needs to be a little bit more attention to this in the cis world. And our anti-androgen options, it's the ones with which you're familiar. So spironolactone is popular. It's often said that it's popular in the United States, but it's actually popular also in less resourced areas of the world. So it's really quite popular, and it's the short of it is a good safety profile. That is, we kind of know what we're getting into in terms of what we need to be monitoring. And cost. The GnRH analogs are very attractive to the endocrine world because they basically shut the axis down and then you can add things back. So they're conceptually very easy to work with a good profile. But it depends on on people giving resources to that. They're not a huge point in terms of care, gender-affirming care in general. It's not the most expensive care there is. So in an affluent Western society, in a healthcare system that just wants to do the right thing, even GnRH analogs are not going to be that problematic. And just putting it out there. So in the UK, in the National Health Service, that's their go-to medication by protocol. Proterone acetate was popular in Europe, and so you'll hear a lot about it, and it's falling into some disrepute for various reasons, which we probably have a chance to get into. Yes?
What about bicalutamide? We use it a lot.
So the question is, what about bicalutamide? And I guess the short answer for me is when we're living in a data-free place, going and using our patients as guinea pigs with an N of 1 is a place where we maybe don't want to be going. And I know things, there's an element of this is all the rage, and maybe this is better, and then there are these like personal testimonials. But we'll get into cases, and we may have some slightly different views on that. But that was just my view. You heard that.
Can you speak a little bit about long-term use with leuprolide acetate, like what you do if you're at that 1 or 2 year mark? People are really happy with where they're at. Are you doing DEXAs? Are you doing other things if you're also giving estrogen supplementation for
Yeah, so the question is somebody using like a GnRH agonist of some sort, and then they are taking sex hormones on top, like estrogen in this case, and do you need to do bone stuff per se? And again, we can talk about that a little later, but the short answer is you're needing to do estrogen. So if you're doing estrogens, it's not the GnRH agonist as far as we know that's your concern. It's the absence of hormone. It's the hypogonadism. So if they're not hypogonadal, I think you should be in a good place. Anyone with a different thing to say? Yeah.
Spironolactone, and have noticed many patients coming in requesting not to be on spironolactone for very systemic level, like concerns about brain fog, cognitive side effects, weight gain. It seems like there's a very large and vocal, like patient, basically Reddit community that's leading to this anti-spironolactone sentiment, but there is a proposed mechanism via increased cortisol levels, at least in some small studies. Are you seeing that, and how do you help manage patients with that concern?
Right. So there's a tension here. So the question is the people who have convinced themselves or read online or whatever that there's a brain fog or whatever associated with spironolactone, and I guess I would just say there for starters, and then we'll have more opportunity for all of us to engage in that space. But there's a tension between two pieces. We have patients who've come from a situation, especially our older patients, where there was a lot of doubt about their talking about their circumstances, and then they were told, oh, they're wrong, but they're not wrong, and so there's a certain trust issue, and then there's the flip side of it, which is we are the medical people, and we really are doing our best to do the right thing here, or we should be, and that's certainly I think the crowd in this room at least represents that. But heavily, I think that's more and more true in the establishment world, and so and it isn't really that we get led by Reddit conversations or what the current rage on the internet is in terms of deciding what's next. But when we're in a data-free space, we do have to be humble enough to know that we're in a data-free space, and that's, again, across all of medicine. So I'm informed by all of these things, like wanting to be respectful and knowing people sometimes have better sense of their body, but I also know, because I spend a lot of time in thyroid, that helps me personally, where there's been more of an opportunity to do some studies to discredit some of the internet folklore, where people say, oh yeah, if I do the T3 this way and the what that way, and everybody says it, and there's a whole community on the internet that even encourages it, and then we do a little study, and the associations are all with what people think they are doing and not what they are actually doing, suggesting that it's all it's more the psychological side. So, but I don't know that yet in a trans space necessarily, and so we'll just have to see. And there's that tension. Yes. Yeah, cyproterone acetate, and again, we'll have chances to revisit all of these pieces. The cyproterone acetate is a progestogen, and we don't know that some of the negative things we've observed in the long term with progestogens, like more breast cancer and more heart disease, are necessarily a class effect, because many of them have been noticed with, let's say, medroxyprogesterone, but there's a reason to have some concern. In the Netherlands and Belgium specifically, where they have opportunities to really look at things, because they have been collecting data for some decades now, the observations are in different spaces even, partly because it's probably younger people too. And they haven't had time to get some of those other issues that are more observed in cisgender postmenopausal women. Are things like they notice these occasional meningiomas in their population that the rest of us haven't noticed, but on the other hand, maybe the rest of us just haven't found them yet. But they worry that maybe it's their cyproterone acetate that the rest of us aren't using, even if it's a rare event. And the other thing they have out there is the whole idea about checking prolactin is something where we who use estrogen spironolactone regimens have not observed this prolactin anxiety in our patients. I mean, we may have the anxiety, but we haven't observed the levels rising. They've gone back and looked even at their let's say their patient, the typical rubric if you have a vaginoplasty or an orchiectomy is that you can cut back on your anti-androgens, right, and just use your estrogen replacement. So when their patients who do that and stop their cyproterone acetate, have their prolactins, if they were a little up, come down again. And so that's what's out there. It's not Horrorsville. It's not panic. It's not sue the drug company, but yeah, maybe if we're thinking for a long-term agent for our patients, maybe it's not our first choice agent. Okay, so you guys will have these slides, and I think cookbook stuff. I'm not gonna, it's we'll have a chance to comment on oral versus sublingual. I'm not going to get too into it right this moment. I'll just talk about a little bit of tension about what we call the first pass effect through the liver, where there is fear that there is associated their increased blood clot risk is associated with that, because some of those clotting factors are increased with some of the oral estrogens, and that's kind of paired with the observation in cross-sectional studies that women across the board, trans women, cis women, who have estrogen patches have fewer thrombotic events than do those who use the oral agents. The only caution is those same meta-analyses show that the connection with thromboses is dose-related, and as we briefly talked about with the androgens, one of the bugaboos with the androgen gels is that they're fairly inefficient in getting much product across the skin, which then begs the question, and people have not looked at this, whether what the benefit of the patch is that it's delivering less medicine. And that's all that is. And it's totally confounding the idea, and the whole idea of first pass effect may or may not even be true. And I love this field because we're actually beginning to ask some of the questions that are like in textbooks in the cisgender world, where they actually there are no data. And so it's like, wow. So I don't think it's just trans and gender diverse people who are going to benefit by this field. It's all of humanity, wherever you are in the gender identity spectrum, because we're going to have some opportunity in those spaces. But so that's that piece. And so I don't know, therefore, if sublingual is addressing a problem, and that's a lot of sucking on a pill for if there isn't a problem to be addressed.
Have there been any comparisons between PO, estradiol versus injected forms?
A comparison between PO and injected, not, but it gets exactly at the question I just raised, because injectables are going to bypass the liver, but they're going to give you these big periods with much more total product given, so they could be worse. And so, yeah, definitely something we should be looking at, or they could be better, depending on which of those things is true.
Daily versus twice daily.
Yeah. So let me just put that out there, because they're a very long-acting agent. So I'm not really sure where twice daily comes from, and I'll just say that much right now. If people So Jen is saying if people feel nauseous, I'm totally okay with that. If you have a logic pattern that's patient specific, but if my patient asks me what they should do, I tell them just take it in a big handful in the morning.
I mean, I 100% agree with you. I mean, one of the things that we have done is, I'm an infectious disease specialist, so if we have people, for example, on regimens for HIV that are twice a day, I tell them to take their hormones twice a day because it's a reminder, and no one ever forgets their estrogen, right? If most of the regimens are once a day, I do once a day, and I haven't seen any issues with nausea or anything like that. I suppose, just like we do with antiretrovirals, some people are better taking them in the morning, some some people are better taking them in the afternoon. So, is my voice not loud enough? I'm so sorry. Did anyone not hear what I said? Okay, I was saying that, it's generally a good idea, at least where I work, to try and tie the dosing to other regimens that people are on. So people tend not to miss their estrogen, right? That's a reality of life. So if someone's on a twice-a-day regimen, maybe they're taking metformin twice a day, then I give them their estrogen twice a day. But otherwise, I use everything once a day. It's just like that extra reminder, and it improves overall care. And I just want to make one other point, which was around the soproterone, which is in the new guidelines, is that the dose is decreased to 10 milligrams, based on actually a very good prospective study that showed that soproterone at lower doses still suppressed testosterone. And I think it's important to know because our patients are getting, at least if you're in the US, our patients are getting medications from Canada, from Mexico, everywhere else. So, I might not prescribe them. They have them. So please, I think it's important to give that little bit of extra information that the recommended dose is now lower, in part because we know it's effective, but also to reduce some of the untoward effects that we may be seeing with those higher doses. I mean, like 5 times higher. People were using 50 milligrams.
Yeah.
Twice a day. It's 10 times higher.
Right. And the person who's from Canada here, actually probably they're getting medication from Canada. Yes.
I don't want to get ahead of myself, but we didn't talk about pellets with the tea before, and then there's also this evolving trajectory with estrogen pellets that I'm seeing.
Yeah. So we'll I guess we'll get to that in my short one in this space, because I don't know if we'll get to that. I don't know if we have a case that goes to pellets. So I'll just say I don't know that I have a strong opinion about yet about route of administration, other than using all the conversation that we're having already as a surrogate for influencing my view. And my own personal view is to get my doses stable before I even consider pellets. And I have incredibly few people who ever get there, because they kind of get, by the time they're stable, they're also kind of habituated to whatever it is we've been doing, and they never come back for those pellets. And the people who want pellets are often the people who are starting, for my experience, are people who are starting out, and it's a little premature, and they're looking for an easier way to do it. And so, and they're exactly not who I'm suggesting a pellet to. I don't know if anybody else has a slightly different experience.
Sure. So just to let you know, I'm not a big fan of testosterone pellets. I don't get any pharma funding, so I get to say whatever I want about any of the products. But what I don't like about the testosterone pellets is that it's kind of like mini golf with the dosing. You could overshoot or you can undershoot. So whether you put in 5 pellets or whether you put in 10 pellets, then you check a blood level. If the blood level is too high, and I've had this happen. I actually had another endocrinologist call me and say, I have a patient who's on testosterone pellets, and his serum testosterone level is 3,000. What do? You can't just take them out. You can't just go plucking them out because they're dissolving. So because of the difficulty with dose titrations, it's also invasive. So as compared to all these other ones, you have to have a scalpel, you have to have lidocaine, you have to tunnel this onto the fat. They can get extruded. Occasionally you can get infections. So they're definitely not a first-line option. Where I think they could be a potential good option is in a patient who really can't take a medicine daily, or who has some adherence issues where you really want to get something really long-acting. Maybe that's a unique scenario, but I hardly ever use testosterone pellets.
And yeah.
Going back to the estrogen, absorption for oral versus sublingual, is there a difference? I just had a recent patient who his labs came back at estrogen 10,000, and normal reference is 300 to 500. And I was like, and they ran it again, and it was 10,000. So, and she was taking it sublingually, but she had taken it 12 hours before she had her blood work done.
Yeah, so the question is about different absorption. I have seen data, and I don't know if it's published yet, but I have definitely seen data where people who genuinely are taking these medications sublingually do get more of a peak and then a quicker drop off than the people who are taking the exact same agent orally, who get have a flatter curve. So there is an element of that, but the peak, we're talking like hours or over a course of the day. So to your specific patient, I have some of these fluky situations, where I'm quite confident that it's not the patient just overdosing on the stuff. And so there are some estrogen assay issues sometimes for some of our patients. And we can talk about the specific maybe offline. All right, so yeah, we have, I think you're next. Yeah.
Well, I was just, since we were talking about all the other options, are you using Tenzo at all, or oral testosterone?
Oral testosterones, I am not, so I can't comment on that. So not much experience for us on the panel. The Europeans do some more of it, and I don't know if I have any wisdom there. Again, coming back to a little being agnostic, as we start to go through various products, a little agnostic on some of the specifics still, where there's a little bit of customization to patient. One other, yes? So two things. So first about nadir, because that actually is an important point, and we'll and I think we will get at that with our cases a little bit later too. Yeah, there's a lot of conversation with no data in that space. In the cis world for testosterone products, the focus was on like a mid. What they call a mid-dose thing, like halfway in the middle, and especially where the period was big, like 2 weeks, or it used to even be 4 weeks, kind of crazy. That really was a nadir for all intents and purposes. What's notable is now that we've switched to weekly more, where the peak is supposed to be at 24 to 48 hours, a 3-day measure is kind of a peak. And so you can just see that even in the cis world, this is just a data-free zone with a lot of hand waving. Some of the logic pattern in the cis world was to be able to give the testosterone that you wanted to give to your patient and not have people criticize you for overdosing them, especially with, I'll tell you, it's kind of not, it's a little nefarious. It's the people with some borderline testosterone levels, and then you're giving them testosterone and people are wondering whether they're abusing, and then there's a little bit of protection where you say, oh no, see, the nadir is fine. But of course, if you wait long enough, everybody's nadir is fine. So I personally am a big peak trough person, but that's just me as an endocrinologist, and I like to see what I'm really doing at some, at some reproducible time point, like after a day, not like right after the injection where it's going to be all over the map. So at 1 day or 2 days, and at this point, like I say, with the 1 week dosing, I'm not seeing, that shouldn't be a huge, there shouldn't be a huge discrepancy, and even the trough shouldn't get too low after a week, and if it does, well then that's something to think about adjusting. All right. So what was? Oh, and the other was the escalation. So yeah, we had a little of that conversation before, which is we go right to the top dose.
Did you say you'd rather have the trough right before at the very end rather than the middle?
I personally am a peak person. I like to see the peaks. To me, that's it's just that's an easier number. It's more to see, and but the peak is at 24 to 48 hours. It's not like right as you're injecting the medication, and And I bet there's a practice pattern element to this. It'll be interesting. We'll talk amongst the panel what we're all doing, where just so long we have some reproducibility. So somebody who's more conservative would be interesting if they look a little more at mid-dose and troughs, and they're saying, oh, I don't like to go to 900, and you hear the peak person saying, oh, 900 is no big deal, but some of it is just the space on the curve that we're looking at. All right, the other thing about twice daily that I just want to touch on is spironolactone specifically, because that's so commonly used. Spironolactone is a diuretic, and we're using it, and if we're using 200 milligrams, you're gonna have some diuretic effect, and that's another reason to take it first thing in the morning. That is anxiety that I'm gonna make my patient hypotensive in the middle of their morning when they're at their best and they had their coffee, excuse me, is not something that I've been observing. But having somebody who isn't waking up at all of a sudden wake up to void at night because I gave them even a small diuretic is something I would like to avoid to keep them as my patient. Yeah, sorry.
So the spironolactone can be done daily also?
Yes.
Eliminate that nighttime.
You can, and exactly. In fact, you should, because I only see harm actually from the nighttime dose or the afternoon dose. Yeah, there was one other. Exactly that, yes. All right, so injectable, we've talked about that a little bit. Transdermals, I think we talked about that. Implants, we touched that, check. Okay, and monitoring. Basically, what we're doing then is that the whole deal is testosterone. Testosterone is what we're following. That you can look at estradiol as kind of part of a picture to make sure that maybe you're a patient on injectables that you haven't, where there's much more room to overdose. That there might be some logic pattern there, but the assay is pretty fraught, as we even heard, and it's going to be the testosterone dose that's going to be a little bit more reliable as an endpoint, in terms of getting to goal. And then it's a BMP here, but I'm really focusing on potassium, and then we'll get into when we have the conversation, because the conversation is how often do you really have to check, how worried about you, how healthy is your patient, how stable are they? But that's the thing that I want to have done at least once and know what they're doing, or maybe have some sense of renal function, which will color how much I'm worrying about their potassium and things like that. Yeah.
Do you do a chem panel after you start them on spironolactone to check that potassium and then don't worry about it after that?
I personally do a potassium. I don't even do a chem panel. I do a potassium check, and after every dose change, just like with any other potassium-sparing medication, and then that's pretty much. And then I'm pretty comfortable. And then spot checking is going to be somewhat dependent on age. And like I say, we can get into that a little bit. I end up with a lot of annual checking because otherwise I will forget eventually, and especially as people are aging. And that's.
So you're saying annual instead of 6 months after your first year?
Yeah, if they're on a stable dose and they're just coming back for refills once a year. I mean, sometimes they end up with 6 months because they came back at 6 months, but that's just practice pattern and practice organization. But strictly speaking, stable. And then same thing as I had with masculinizing therapy, with feminizing therapy, really shifting this list of things that looked like they were things you had to worry about with hormone therapy, which are really primary care concerns in general, and it's kind of that same list again. And a routine screening, again, is focused on the organs present and lack of data among transgender people, where, therefore, you have to think to, that you want to monitor organs to some degree. And the SOC 8 primary care really shifts its focus in that direction, where you want to monitor what is there. And the rubrics we have right now are heavily based on cisgender data, and maybe that's just what we do so that we don't lose our trans people accidentally. And we might be mindful of alternative realities, like if you're doing mammograms, the data on cisgender people assume estrogen over a certain period of life until you began that testing. If you have a trans feminine person who's had less lifetime exposure to estrogens, is she going to be at less risk? Maybe. The data in the Netherlands are that they're seeing less breast cancer among their trans feminine people than among the background similar age Dutch population. So that could make sense, but we don't have a rubric for that and say, oh, you only have to have your mammogram every other time or something like that. But we could have that at the back of our mind. All right, and then this is, I'll go through this fairly quickly. It's just kind of some model, for people who like pictures, and you can have all these slides afterwards, that estrogens, the point is, notice that I am drawing it feeding back on the hypothalamus and the pituitary and not action on other tissues, because we're using it as a tool in that space heavily for openers. And then spironolactone, the action that we know is it's supposed to be a mineralocorticoid receptor inhibitor, but at pharmacologic levels, there is overlap and there is action on androgen receptor. We've known about that for about half a century, and to the degree where the original concerns were raised by cisgender men who were not happy with the anti-androgen effects they were having when this is being used as a blood pressure medication. There are in vitro, clinically, many of us have observed that spironolactone may decrease the testosterone levels to a degree, and there are in vitro data from papers from the 1990s that show that can be true, that the testosterone levels could be lowered, but that is actually not the best established effect. And so we want to recognize that, especially if we look and testosterone levels have not come down in a given patient with spironolactone alone. That isn't what we were expecting either. It's not like a fail. Maybe we're going to use estrogens, and we recognize that the overall benefit of spironolactone is going to be greater than you would think by measuring the testosterone alone, because we're not able to measure that impact on the receptor. And then let's see. Oh, and this is more or less saying various things. So known and unknown mechanisms. So known is the androgen receptor, and the unknown is like that a little bit hand wavy impact on synthesis. Let's see, the potassium thing I think we've discussed, so it's good when we go through the slides, and we already got to it by the questions. And the hypotension and the brain fog, we already had a little of that conversation. We'll have more of that. With regard to GnRH agonists, really it's the accidental observation when these were being used as developed for fertility that you need pulsatile release in order to have the sex steroid axis to be stimulated, and actually in a bolus it shuts everything down, and we've all been using it that way ever since, happily, for those purposes. And so very, very clear, very effective, very, very powerful agent. Cost has been an issue, but like you heard me say already, certainly in an affluent medical system, this is nothing compared to Hep C or cardiac surgery, and so nothing we do in gender-affirming care is particularly expensive, even our surgeries. Progestogen. So let's talk about that a little bit. And I think this is the point of this slide. You can have it and look at it too later. But the point of it is to remind you where things are sitting in terms of that cholesterol pathway going to different hormones. And so if you imagine that we're taking different progestogens, and they might have different impact based on different enzymes and different cell types, just the heterogeneity of impact that they're going to have in terms of if it's going to be more of an androgen-like experience or more of an estrogen-like experience. And so we want to get a little away from overstating what our expectation is going to be even with these agents on a given tissue or even in a given patient potentially. And I think we've already talked about them a little bit. The patients, what they're reading online, and actually it's not just online, because Dr. Pryor at University of British Columbia, I don't know if she's still at UBC, but definitely in Vancouver, is a big proponent, and has been a real activist and advocate for trans people for decades when nobody was taking care of the patients, and is very convinced that adding progestogens to the estrogen regimens helped her patients with breast development, and so she's actively promoting this, and yet the data are, you know, the reality is kind of what we've already been discussing in that space, and we'll go through that a little bit. So yeah, that's going to be where the SOC8 is right now, because those are the data that we have. Is going to pretty much push back on using progestogens as an agent, where we have some long-term harms associated, and we have a lot of people thinking, oh, it's physiologic, blah, blah, blah. Yeah, I mean, these are things to study, but no evidence that any of them are true yet. Yes?
Does the SOC data look at, say, progesterone versus other progestins, also differentiate between sort of the cisgender menopausal literature where a lot of progestin considers testosterone?
Right. So that's a great question. It's is there a conversation between, let's say, a micronized progestins versus medroxyprogesterone, where most of the data sit, or is there recognition of the fact that most of our data are among older cisgender cisgender women versus, you know, use in, let's say, younger people in general, and specifically trans folks. And so the short answer is there are no data to parse all that out. And yes, do the guidelines, like in their little explanatory text, say, we recognize that this is not blah, blah, you know, may not be for sure that you will find those words, yes. All right, so 5-alpha reductase inhibitors, bottom line of it, here, let me just, is that their point of action in that huge, messy cascade is blocking testosterone to dihydrotestosterone, which is a more potent testosterone, and that's it. It's kind of niche and tissue specific. And so they make sense for, and the data exist for people with what we think of as male level testosterone levels when you are trying to avoid some of those specific concerns, like prostate growth and male pattern balding. And that's the story. And so that, and although it's typical to see them on lists of feminizing agents, really I think they're more logical probably for your transmasculine individuals hoping to have a little less balding with their testosterone or something like that, just like your cis guys might be thinking. I'm not a big fan for various other reasons, but at least there's a logic pattern there for your trans feminine folks. If they are if they're failing, if their androgen levels are high, then maybe there is a role. But if they're succeeding in getting their testosterone levels down, the logic isn't there. In fact, the drug company historically was trying to find data in that space in order to pitch this to cisgender women too and expand their market, but they could not get good data in that space. So modestly protective of scalp hair. So just for perspective, you know those real shiny heads? So if you use it, you eventually can get a fuzzy head like I have, you know, so just it's modest. All right, and then VTE risk. I think we talked about this already heavily, which was just that it's more of a dose connection thing than a route of administration thing, maybe because it's confounded. And the only other thing I'll say beyond what we've already discussed is that there's a low incidence anyway. Like the one study out there from a few years ago, we're looking at about 700 trans women on oral estradiol for a couple of years, had one person have a VT event, you know, so it's not like they were all keeling over and it was this epidemic of horror, and that was not even a life-threatening event. Off the top of my head, I don't remember, but it would be in the like 4 milligram oral estradiol range. Yes. Yeah, that's a great question. How do we get the word strongly when I'm telling you that it's not that big a deal? And and I guess the short of it is, from a data perspective, the data are strong. If we're talking about just like statistical significance, where we have large numbers of people where we give exogenous estrogens, and that's cis or trans. And actually, let me just go back to this slide, because I think it actually makes the point. Oh, it doesn't actually, because I don't have the line in there. But all those purple lines. So if we just, all those purple lines, the farther to the right they go, the more increased clot risk there is, but there's never a point where we're seeing decreased clot risk. And that's actually the only point I want to make. And so the statistical significance is high, that there's going to be that exogenous estrogens in some circumstances are going to be associated with clot risk. And the point I want to make, though, is that may be true, and you may have a great p-value, but for a given individual, it's very low. I actually, this is what I tell my patients. If we look at the clot risk of bearing a child, and then we compare that to abortion. Abortion is about 1/10, and then if we compare, not 1/10, a quarter, and then if we compare that to using oral birth control, which uses ethinyl estradiol, the product that we avoid in our cisgender people, in our transgender people, if we the lifetime exposure to ethinyl estradiol is like about a quarter of a risk of an abortion, and then we go to 17-beta estradiol, which is even less thrombogenic than ethinyl estradiol. You kind of see where this is going. It's not that it's not true. Strongly believe it's true, but I'm pretty far down there. Yeah, okay, yes. And then I think, were you motioning that we should?
So maybe as you answer the questions in the panel, can move up to the.
Yeah, perfect. Okay, good. So let me, go ahead.
Can you speak about changing doses? So as an OBGYN, we're always taught that changing estrogen dosing is actually your highest risk. And I'm particularly worried about this with my patients undergoing surgery and my wonderful surgeon colleagues who want to take them off their estrogen, where I would argue keep them steady, give them anticoagulants if we really need that. But I'm more worried about going on and off as thrombotic risk rather than keeping them on what is good for their whole world instead of.
Right, and by the way, and you are not a plant. Okay, so the that's actually a huge point. So I want to say it again. While in the endocrine world, there's all this recognition that that exogenous estrogens may be associated with increased clot risk and some fear that it may be additive to other increased clot risk, but in other spaces where people look at some of the literature, which are heavily come from stopping cis women who are on birth control pills and then resuming those agents, after some operation, and then observing increased clots in that circumstance, the interpretation, and it's in the GYN space, which is why it's great to have everybody here, because we're smarter than each other in all these different ways. And also, by the way, the hematologists have that same view, that the stopping and starting is a prothrombotic maneuver, and therefore you would actually not want to stop somebody's estrogens in a perioperative maneuver, because you would increase their clot risk, you would fear. And so at Mount Sinai, we have these data, because we actually had this conversation a little bit, and these are our data, which cover all the points we just made, which is basically about 500-odd surgeries. We held the estrogens preoperatively, and we had one person have a thrombotic event, because it's a university hospital, and we're really aggressive with early walking and heparin when you need it, et cetera, et cetera. And so our DVT prophylaxis protocol is aggressive, and it's not very likely. So we had like this one person. Anyway, then we had that second group is like 600 surgeries over about an 18-month period, where we just went right through and followed that paradigm of just keeping everybody on their estrogens, and we had no recorded events. So I don't want to argue that it was safe, that the difference of 1 to 0 is, it is infinite, but but that's statistically significant. But yeah, I think it really makes the point, and it also makes the earlier point of in this aggressive setting, there wasn't much of a thrombosis risk either way. All right, so yes.
I just want to make the comment that it might really take some doc-to-doc encouragement to ask a surgeon community if a patient has, mental health concerns. As a mental health therapist, I've had quite a few people that I was very concerned about them going in. They had a terrible time going off of their estrogen and getting suicidal and things like that. So, but I wasn't able to convince the surgeon otherwise. So.
Yeah, so what are we doing in this space of convincing our surgical colleagues of the data? And yeah, that's almost, that's, when we get to surgery, when we bring Alex into the room later this afternoon, let's go there a little bit, because that actually is a bit of a space, because I have some of our surgical colleagues who are meeting right in another room right now, are really receptive to the wisdom in this room to help guide and do the right thing so that they could just focus on their artistry. And others, they're like baseball players. They're spitting on their nose and God knows what in order for better surgical outcomes, and they're going to need a little bit of hand-holding in that space. So.
But also, I think it's important to consider the fact that all of our patients, no matter whether they're on estrogens or not, are needing surgeries of various types, and we're talking about gender surgeries here, right? When you bring that data in.
The data I showed you are in the context of gender-affirming surgeries specifically. That's right. And you're saying our patients are getting many, many surgeries. But right, is this generalizable? I think so, but that's it. Okay. All right, long-term healthcare risks, hypogonadism we're avoiding, super physiologic levels, so the erythrocytosis we talked about, VTE risk when we make the dose higher, and we are done with that, just getting us all on the same page. It's good that we got there. All right, so do we want to just go right to cases, or do we want to give people like a little break? Because you and I went right back to back.
Cases. And then we'll have a break after cases.
I'm just thinking, do people want to pee? I don't know, it depends how old they are. Okay. Okay, the break is at 11. So hold it for 45 minutes and let's jump into that. All right, and I don't know who's doing case, one of you should probably get up and present. Yes? Or should I? Yeah, I don't care. Okay, I don't know, just a variety, so I'll rest my voice. Yeah. Okay. All right. So Michael is going to present the cases because the people who needed to pee are out. Okay, quick. All right, and then we'll come back. We're going to plow right on with cases for the next 45 minutes.
Yeah, I mean, if we get like 5 minutes, there were also 2 mistakes on the slide. So, I mean, it might be.
Just FYI, there are plenty of seats here on this side, and so those that are standing, if you'd prefer not to stand, we have plenty of seats over here. So thank you for coming to the advanced cases. Feel free to get up and stretch if you need to. My name's Michael Erwig. I'm an adult endocrinologist. I'm at Beth Israel Deaconess Medical Center in Boston, and it's a real delight to be with you all in person. So let's delve into the cases. So I don't believe that any of us has any financial disclosures. However, as was mentioned, we will be discussing a lot of off-label use of medications as they were not officially approved for gender-affirming care. And the objectives are to discuss advanced cases in feminizing and masculinizing gender-affirming hormone therapy. So we're going to start off with the masculinizing gender-affirming hormone cases. All right, so case 1 is Michael, which is actually not me. So Michael is a 23-year-old transmasculine adult, uses he, him pronouns. Incongruence was noted at age 6, struggled with secondary sexual changes that occurred with puberty around 11 to 13, especially as breasts and menses developed, came out as a lesbian to his parents at age 16, who were eventually supportive. In college, he met someone who was trans female and realized that he had been experiencing his whole life was gender incongruence. He's a former smoker, quit last year. He's monogamous with a cis girlfriend. and past medical history, anxiety, unmedicated, but sees a therapist. He had his appendix taken out at age 19, father with diabetes, hypertension, and depression. His only medicine is an EpiPen, allergic to kiwi, baseline labs, a normal blood cell count. All right, so discussing the risks, benefits of gender-affirming hormone therapy. This is a little bit small print for me to read. I may have to move kind of closer there. Let me get the mic, and I'll move a little closer to that screen.
I think if you animate it, the sort of highlights come up.
Let's see. Yes, so timeline here. So timeline, this is so important because when our patients come to see us for hormone therapy, they want the effects right now. They want it today. They wanted it yesterday, okay? They're very eager to start hormone therapy to get the effects. So it's really important to set the expectations. So I often tell patients that, you know, the average cisgender person went through puberty over a course of years, not days or weeks or months. And it's very variable depending on the organ system as well. And so there can be actually very subtle changes to the voice with low-dose testosterone within several weeks, whereas changes to, you know, facial and body hair, for example, can take over a year in both transmasculine and transfeminine patients to see a lot of effects. And so that's one big issue here is timeline. What changes, what doesn't change. And again, I always like to emphasize there's so much individual variability in this area. So it depends on your genetic background. So if you come from a family where all your relatives don't have much body hair, you're probably not going to get a lot of body hair if you get on testosterone. Or if you're from an ethnicity culture where there is where there is much more body hair, you're probably more likely. Same thing with breast development and other features here. Same thing with the androgenetic alopecia. So this happens in individuals who were genetically predisposed to it. So not every transmasculine patient who gets on testosterone would get the alopecia, depending on their genetic background. And what is permanent, what is not. This is really important, okay, because this is a big decision, pulling the trigger on whether to start hormone therapy. People have to know what they're getting themselves into, particularly with the explosion of non-binary patients within the last few years. There are a lot of patients who are contemplating hormones. They may want to get on hormones temporarily, kind of take them for a certain duration, and then they get an effect and then stop the hormones. So they need to know what is permanent and what can go back to baseline. And effects on fertility. There's going to be a lot of sessions on this. There's still a lot that we don't know about this topic. My kind of go-to lines that I tell trans feminine patients is I say that that long-term high-dose estrogen use can suppress sperm production, and you'll likely not be fertile if you were on the hormone therapy. However, there was a very interesting study from Germany where they looked at trans feminine patients who had orchiectomies, and they had 3 different groups. One of the groups, they said, continue your hormone therapy up to your orchiectomy. Another group was told to stop their hormones 2 weeks before, and another group stopped 6 weeks before. In the group that stopped their hormone therapy for just 6 weeks before their orchiectomy, half actually had normal fertility. So it is still possible for a lot of trans women to be fertile if they were to come off the regimens, but we can't predict. Now, in actuality, what we tell our patients, if you're interested in having a biological child, the safest thing to do is just sperm bank. Put that away so that in the future, if you need it. On a practical level, though, I can tell you, because this is part of my standard template, I always ask patients, are you interested in having a biological child? And I would say at least 90 to 90% will say no right out. And for the ones that are interested in having children, they're often very happy with adopting. So it's actually very rare that I get a patient who said, yes, I want to have a biological child, and it's usually more if it's a 19 or 20-year-old and the parents in the room, and it's more the parents' concern than the 19 and 20-year-old, because usually having a child is not on the first kind of thing in your average 19 or 20-year-olds. So I'd like to open it up to the panel to get their other perspectives about timeline changes, permanence, and effects on fertility. Josh, do you want to start?
I don't think, I do have a microphone, look at that. Can you hear me? Does this work? Okay, beautiful. All right. So yeah. So the main thoughts that I have in this space, I think I'm just going to go right to fertility. Really, is that the other side of it is that people are very loath once they're in the midst of treatment and on hormones to do the major interruptions that might be necessary. And I'm speaking specifically to trans feminine people. Where getting sperm growth and such is going to take 3 months minimum, but really it could be 6 months. And sperm banking is a relatively straightforward thing and is something that's achievable by a lot of my patients. And so that's just the other reality. Certainly in the oncology world, they simply do these things by protocol to kind of remove the concern from the patient even overthinking it or getting ahead of themselves in life, because I think there's an element of that among our patients too. What fraction of our patients avoiding regretting not having made that decision later is it worth to do a bunch of sperm banking up front among everybody? So that's my one comment in that space. And my one other comment regarding my transmasculine individuals is it's an area where I think we have some opportunity to learn some things because I think some of you may be aware we have a case report, so that's hardly like a conclusive study, but we have a case report out of Sinai, and I know others have had similar experiences. They just didn't publish, and I just wanted to get it out there so we could so that it's actually visible. Of a transmasculine individual where it worked out for his circumstance that he was in a relationship with a cisgender female partner, and it worked out for his circumstance that they used his eggs with donor sperm, and we retrieved eggs from his ovaries that were still in his body because he didn't take them out, even though if you'd asked him 10 years prior whether he was interested in having kids, he had said something between I don't know and no, and didn't do anything, but he didn't take his ovaries out either. So there they were. We stimulated, we got eggs, we did use the donor sperm, we did the implantation in the cisgender partner's uterus. The child is 3 years old, and so just something to be aware of in the background. I don't know if how reliable that is, but it can happen.
For how long was the patient on testosterone?
That was years, maybe 10 years, 5 years, something years, not a year. So yeah, so let's see. Do you want to call people out? Yeah.
Sure. Question.
Yeah.
Sperm production versus recovery when those meds are held. The anecdote is I do a lot of Lupron, and my anecdote is like N of 5 or so people who need meds held after even a short time of getting on Lupron, and they don't produce the Lupron even after a 3 to 6 months.
So I guess and I don't know, Michael, you may have more to say about some of these nuances, but so I would wonder, so there are two pieces. When I say 3 to 6 months, I'm talking about 3 to 6 months of being really free and clear of the agent. And if you're using a long-acting agent like a Lupron, and even if you think of it as a monthly agent, it's longer acting than that, then I think you're adding on, I don't know how many months with some variability among biology. I don't think there are any data for separating among products, but I think that has to be part of your equation.
Yes, I mean, as you'll see in this field, there is just so much lacking. So that would be an amazing study to do, to randomize a group of 200 patients to these different groups and then follow semen analysis every month and then see the differences. So I'm not aware of any really good study that compares the different agents over time. Yes, Asa?
So, is my mic on? So I was going to say that we do have, for the SOC 8 update, we do have different chapters having like their updates during this conference, and I know that the reproductive health chapter goes into this in a lot of detail, and it may actually be best if you're super interested, because we have like 12 cases. If you're really interested in this, that you go to that session, and the session is, do you know? You must know. Monday afternoon. So, and it's going to be one of the more exciting updates, because the new standards of care, just for eligibility, have a new statement that you need to be discussing reproductive health with clients before physical intervention. So I think it would be really relevant to everyone who's here.
And
Yes,
I just
and-
want to say, to the number of cases, we have, I can tell already, and I love, this is so much better than Zoom. We're no way I don't think we're getting through all our cases. So if you have comments and questions, find a way to segue them into the case at hand.
And I'm going to, yes.
About, like, how do you guys have this discussion? Because this is sort of meant to be like the informed consent discussion, right? So do you use a piece of paper? Is it a pamphlet? Do you have learners with you? How are you guys having this kind of risk-benefit discussion with your patients?
So I definitely do this all in person. I definitely like in-person visits over virtual visits. Especially for new patients, especially patients who I want to do a physical exam, want to counsel. It just is a much better at establishing the rapport. So this is definitely, a part of the visit where I'm not typing my note, I'm not looking at the computer, but I'm actually having a face-to-face eye conversation. Say, okay, I know you've probably read about a lot of the effects. You probably know trans people. You've probably been on YouTube, but I just want to review them with you just in case there are any effects that you may not have been aware of, or of the timeline, and then give them a chance to answer questions.
And the one thing I want to say in that space here, and thank you, Erica, for speaking up, because I actually forgot that we had this agenda too, which is people are out there making some of their patients sign consent forms still. It's like vestigial from an era when first we were making them jump through mental health hoops because we were treating them like it's a mental health concern. And then there was kind of this rebound to a la carte, do whatever you want. I'll just as long as you're willing to sign a piece of paper. And some of these pieces of paper got developed in that context. And I think as we get this much more mainstream, which is where I personally think it needs to be, then this is more a list of reminders of things we want to discuss with our patients, and we're certainly not making them do anything differently than we would be doing with our cisgender people for similar products.
Yeah, I mean, and I agree with that. I mean, we use medications off-label all the time. We don't require people to sign consent forms. That being said, in our institution, we do have them, but we use it as an educational tool that people can take at home and they can review. Because, when you're getting your hormones for the first time, or you're seeing someone for the first time, I mean, you're just yes, 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 yes to everything. Like I know. Like, I need that shot. Like, I need it now. And your brain doesn't really take in everything. There's a lot of things to discuss. So having that piece of paper that you can go home and refer back to, I think, is super important. Also, often caregivers or family members who are with the person often like to see something that they want to read. I think that's fine. But yeah, the WPATH, the standards of care, do not require a written consent form, even though some insurance companies may want to see this, or other people may want to see it maybe at your institution. So, we're trying to push away, but think of it as an educational tool. I think that's the best.
And I'm just going to open this also to Gail, because she's in charge of the whole session, and to Asa and to Josh. We're obviously going to balance trying to get through cases so that we can learn about them versus a lot of the questions, because there is so much unknown. So Gail and Asa and Josh, if you want me to move faster, if you want to do a time, that'll be a signal for me to move on. Either of you three can do that at any moment. So let me just have Asa finish.
Yeah, and just so you're clear, I just want to make sure that people have time to pee at some juncture, and and that the people who wake up at 11, we welcome them when they arrive.
Yeah, so feel free to get up and leave if you need to take a bathroom break. Asa, did you want to have any final comments about this slide or perspectives?
No, I think we can move to the next slide.
Okay.
This slide is available. So we have all the you'll have access to all the slides.
Yeah. This is just an example of one center's consent form. Yes. There are many out there.
Yes, and one thing that we didn't cover, well, one of the bullet points here is risks. Patients are often focused on all of the good things that are going to happen to them with the hormone therapy, and everything is a balancing act, and there are potential adverse effects with all of these regimens, and so we do need to point this out, and this particularly comes into play with a lot of the kind of non-conventional regimens that we've touched upon, some of the medications that are not standard as well.
And I actually want to say one thing in that space, and which is risks are not all risks. They're not all the bad things that happen to you. They're just the things that happen to you. So a conversation that I have not infrequently, especially with trainees, is, what about somebody who wants like a reduced hormone regimen? And so for that person, the risk is that they're really sensitive to the medication. It's not that I'm so nervous about hormones, but it's like I'm going to give you low-dose testosterone. You might really get a great beard with low-dose testosterone and be gendered masculine. Are you going to be okay with that? And when people say, oh, sure, then I know we're aligned. And when are people like, well, that? And I was like, well, then we back off a little bit.
All right.
Yeah, do you want to, I think there are...
Yes, question in the back. Yeah. So in particular, physical exam, so I generally, for all my new patients, I'll do the same physical exam. For trans patients in particular, I'll pay attention to, baseline acne, for example, if I'm about to start testosterone, just to know if there was any at baseline. I've actually moved away from doing routine genital exams. At the initial visit, I used to be kind of gung-ho and very thorough, and I need to document this, and I need to document that. And then I found that a lot of trans patients are very uncomfortable, trans feminine patients. So I've actually not done that unless there's a clinical concern that I have or that something else has kind of come up.
So,
yes.
Oh, I just wanted to say one thing. Yeah. I mean, I think it's about the relationship and the rapport you build with your client. I mean, I think as long as you're getting this done, maybe it doesn't have to happen on the first visit, but I will say I've picked up a testicular mass in a trans femme patient who came in, kind of, derailed a little bit of what happened next as far as being able to initiate hormones. And also for another client, detected a lump in the breast when I did an exam, and that clearly we needed to evaluate. So, just remember that a lot of people have not been in medical services, often have delayed preventive care. Please don't go the route of never putting your hands on your patients, because just like I've shown, like you will pick up things. And these weren't, these were folks who were in their, like the young woman was in her 20s, and the other patient was, I think, like 40 something. But still, it's important to do.
Yeah, I want to jump on the pushing back a little bit on the exam piece, which is, so I live in the endocrine space, so I'm probably, actually my practice is probably a little more like Michael's, where I'm doing a little less physical exam. But on the other hand, I am looking that somebody's doing a physical exam. So if you've got a primary who did it already, then I don't need to torture you. But if you're all out there, then somebody's got to look at stuff. And so I do have that conversation with the patient, just, and just that we have a plan here. Gesundheit.
Okay, let's do one more question and then we'll move on.
You were talking about the timeline of changes. I wonder if there's anything written about if this timeline is the same for someone that starts hormones at 42 years of age versus 16 or 17, like when they haven't completed their inner puberty, if the changes happen more quickly. Is there anything in that?
So what's been published in the standards of care and in some other documents is more looking at the onset of the effects and how long it takes for them to kind of peak and plateau, rather than at different ages of when you start the hormones. But there is a table in the standards of care about when to expect the onset versus when you'll see kind of maximal effects. All right, well, in terms of starting transmasculine patients on testosterone, as Josh mentioned, we often use testosterone cypionate. It comes in little bottles that are usually 200 milligrams per ml. In the state of Massachusetts, where I am, there's a lot of controlled substances regulations and insurance stuff, and I can only prescribe the 1 ml little vials, whereas in DC, I used to have the luxury of prescribing the 10 ml vials, which could last for 6 months. So it depends on where you live here. And the size of the needles really depends on if you're giving it intramuscularly or versus subcutaneously. So if you want to get into the muscle, it has to be a deeper needle because you have to pass through that fat layer. So the needle size for an intramuscular injection is generally going to be 1 inch to 1.5 inches, depending on your patient, whereas a subcutaneous injection into your abdomen is going to be usually a 5/8 inch long needle. And a lot of patients do prefer the subcutaneous route just because it's a smaller needle and a shorter needle.
Yeah, and I want to jump in right here and say, don't overthink this. I'm customizing my needles to my patients, honestly. Do I ever need it to be an intramuscular injection? I don't really. So, like, if I have a patient who thinks they're doing it intramuscular, but it's actually not getting all the way down there, sub-Q works anyway. So, it's mostly about keeping my patient comfortable. And I have, a wide range. I have patients who want to get it in there as fast as possible, and I have patients who want to use the tiniest needle that they could possibly see. And I don't know, Asa, if you have a thought in that space either. But I guess that's where I'm going, not to be so formulaic.
And just FYI, these vials also come in a different concentration, which is 100 milligrams per ml. And I found that when I asked my patients, particularly if they're transferring their care from another center, what dose are you on, they're never going to tell me the milligrams. They're never going to say I'm on testosterone 50 milligrams. They're going to say I'm doing 0.3 or I'm doing 0.4. And of course, you need to know the concentration of the vial and not necessarily assume that it's the 200 milligram per ml.
Right.
And then I always write in my note, just to be really clear for the primary care doctors, other people, to know, I'll always put in the dosage with the milligrams and the ml so that there's no confusion in the notes for other people reading it as well. And I have found as well that it sometimes is more difficult for patients to get this 100 milligram per ml vial due to insurance reasons or just pharmacy kind of backlog issues. So I would say most of my patients are on the 200 milligrams per ml vial.
Wait, let me back up to that slide a second because I see a typo. Yeah, fine. So just so everybody be aware, anybody where that's hurting your head, we see it. That's 200, not 20. It's the first typo, actually, on the entire slide set this morning.
All right, so here's a picture here that basically shows the needle going into the subcutaneous area versus the muscle, and that you have to go deeper, and there are different angles here. I've seen different people recommend different things. I'll ask the panelists what they've heard. I basically defer to our nurse in clinic who does the teaching of this, and she has told me that for the teaching for the IM, she typically recommends a 90-degree angle for the IM injections and a 45-degree angle for the subcutaneous. Does anybody else have any recommendations, or does it not matter? Yeah. Yes.
Yeah, and I actually kind of like this picture as kind of showing you, other than that intradermal one, pretty much everything should be fine.
Yeah. But I just want, going back to the dosing, I mean, I tend not to see it as much of an issue for testosterone, but definitely for estrogen. There are so many different like formulations, and the vial, people can be switched from 40 milligrams an ml to 20 to 10. So those definitely, like, even just take a picture when you come in, so we know what you're taking, because that's like you didn't mention it before, but a huge cause of variations in serum estradiol, or that someone was prescribed a different concentration.
Correct. And also the syringe size varies as well. So the smaller the syringe, with a 1 ml syringe, you can be much more precise with your dosing, whereas the pharmacies I found will often give the patients a 3 ml vial. So if they're trying to withdraw a 0.2 or a 0.3 ml, it gets much more difficult to do. And so I'll often encourage patients, because they often don't know this, I'll say, just for your next visit, just bring in your supplies. Let me see what syringe you're using, what you draw it up to, just to confirm, particularly if there is something inconsistent. If you're prescribing a standard dose and the testosterone level comes back at 1,500 and you're like, well, you're only on 50 milligrams and that was a week after, have them bring in their supplies just so that they can confirm. Yes, in the back. Not for the doses that we use. Yeah.
Yeah, you
Yeah.
can safely do 1 ml. That's not an issue.
Yes.
Yeah.
Yes, and this study here, this SPRAT study, what was nice about it is it actually compared transmasculine patients who were on the intramuscular and then they were switched to the subcutaneous and they were asked which did they prefer, and almost everybody preferred the subcutaneous. Yes.
One of the reasons, or the reason that the large vials, the 10 ml vials was discontinued, and I don't know if anybody still has access to those, is we work with a pharmacist and said that the, not the potency, but they're not safe. They're not safe past a month, is what we've been told, is that the, the what?
Contamination rate.
Yeah, well, it's not even contamination, maybe that, but the preservative doesn't make them safe after, that's why they're one injection, and that's why it only safe costs a vial after you use it. And I think with the estrogen, they're good for a month. So nothing over 28 days.
Right.
Say the same thing about insulin. What comparisons say the same thing about insulin and a type 1 diabetic, and I can tell you that insulin from when I was 6 years old is still in the vial.
Yeah, so just kind of summarizing is some of the pharmacists have talked about there being lack of stability beyond a month and that being an argument for the smaller vials, and then there was a little pushback on maybe that's overstated. So I think that was a summary of that conversation. And Michael, I just see a couple of hands over in the corner
Yes.
there.
My question was actually in relation to pharmacists. So I've had pharmacists push back and say that because testosterone on the vial, it says intramuscular injection, they refuse to dispense it when I write it as subcutaneous. I feel that that's very frustrating because they're not here. We're here. I sent them that article.
Right, right. Yeah.
Right. So there was a concern because we got pushback from some of our colleagues, and we have this, by the way, in my institution too, where where they say, well, it's IM, there's no study, blah blah blah, as if there ever will be one by the drug company. So we have that paper, and now that's part of some of the agenda of SOC is to and it does say IM or sub-Q right in there so that we can say, these are the international guidelines, adjust your, how do you want to do this procedurally in our institution to...
Yeah, I think it's unlikely that we're going to get the drug company to take intramuscular off of there, but if we have the study we can fax over, maybe they'll listen.
Exactly.
I sent it to the pharmacy and it works.
Yes, there's a question as well. I'm not sure I understand the question. It's about safety of the esters. Is there a particular ester or formulation? Mm-hmm, mm-hmm. Right. Mm-hmm. Mm-hmm.
Yeah, that study hasn't been done, and you're quite correct. So we are really only talking about testosterone, cypionate, and enanthate here. But for mixed esters, the study hasn't been done, and maybe that's something you could look at.
Right, and by the way, I don't know that I would predict a problem, just to be clear, based on, but so that's all. I would guess it would be okay, but like Asa is saying, maybe you want to do a little 10-patient thing and.
Right, and I also just want to make one other point. Yes, it's very difficult to get the 10 ml. If you go to a compounding pharmacy, you can. I mean, I think the other side is to think about the impact on the patient when, as a controlled substance and trying to get these medications every month, there are going to be delays. It is so frustrating. It causes a lot of anxiety, a lot of anger. Sometimes it's just easier to switch and use a compounding pharmacy so you can get the 10 ml. And I'll just say that from a,
When the insurance companies won't pay for more than 1 month supply, then we do multiple prescriptions and e-prescribe those and just put do not fill before a certain date. That's what the pharmacist wants. And so I don't have to see them. But I can put the testosterone, the 2 mLs and put refills on testosterone for most of us. Sometimes
Yeah.
But this is different in the US anyway, state by state. In New York, every single time we fill a control prescription, we have to actually enter it into the database for the state. We cannot prescribe 3 months at a time. Absolutely not. In New Jersey, you can. So, I mean, it is. And I
Yeah,
don't
there's
know
all these
exactly.
workarounds depending on where you work. One other option that is also potentially available is if the issue is with the insurance company and all these rules, patients can actually pay for it outside of the insurance and just say, listen, I'm just going to pay in cash and not have to deal with the hassle, just because the testosterone esters are not that expensive. And so, back when I was in DC, I calculated out for a vial that lasted 6 months, it worked out to be like $10 to $15 a month. Yes.
What we usually do is prescribe 1 ml single-use vials, but we tell the patient don't throw it away, like get your 0.6 or 0.3, and then next week the other 0.3 from that, so they have a little extra.
Right. Perfect. Yes, question?
Just kind of along those lines, I was going to say, that's the patients transfer in and not heavily told that, like, supplies, syringes and things like that can also be purchased from online, at least in America. Sorry to be so America-centric on those conversations, but you don't have to have prescriptions for supplies, so you can buy them from Amazon or wherever and get lots of them. And it's much cheaper than trying to deal with pharmacies that are always screwing up the
Yes, exactly. Exactly. All right, so Michael came back 1 month later, so he's on 50 milligrams intramuscularly. Who's Michael, right? No. And he's doing well, no injection site reactions, skin is maybe slightly more oily, feels like he has more energy, no other changes or side effects. And then you increase the dose to 60 milligrams subcutaneously. So you're switching from intramuscular to subcutaneous and also increasing the dose slightly by 50 to 60. So then Michael comes back at 3 months later. He's on the 60 milligrams subcutaneously. He's doing well, but acne is more of a problem. Some facial hair, peach fuzz, vaginal dryness, maybe some vocal changes, and is still having periods. And so part of this, can obviously be explained by the higher dose, and the studies that I've seen seem to show that acne tends to peak and be the worst at about 6 months after starting testosterone. So Michael's kind of moving closer towards that point. And here we get some routine blood monitoring here. So you can basically see they've highlighted platelets, the hemoglobin, and pay attention to the reference range here, okay? Because the lab obviously is only going to have what's in the patient's electronic medical record. They're not going to know what went on with the visit with you. So they may, so they're usually not going to know that the patient is trans or that they're on this hormone therapy. So always keep that in mind for some of the lab values that are gender dependent. So for hemoglobin, hematocrit, that's a big one. Yeah, do we have a question in the back? Nope. Okay. So in the testosterone as well. And so when I put in my notes, when I cite in testosterone values and it's this testosterone reference range, I've gotten into the habit of just free texting, getting rid of the reference range because it really doesn't apply to my patient population. So I'll just put testosterone, this is the concentration, this is the nanograms per deciliter, not to confuse those reading the note. Patients will often get very anxious about any lab value that falls out of the reference range, and people will kind of create diseases based upon this. Oh, this is low, I need to get on this, or this is high. And you basically have to counsel patients. I had a patient come in and see me last week, not to digress, who basically wanted every hormone level checked because she wanted to optimize her hormone level. She just wanted me to order like 200 or 300 hormones, and I just told her, we don't do that. And it needs to be really symptom guided. And because the reference range, which some people call the normal range, is based upon 95% of the population, 5% of the population is always going to fall outside of the reference range. So you're going to have 2.5 at the bottom and higher. It doesn't mean that anything's wrong with them. So if you order 20 tests, chances are one of them is going to come back high or low. It may not necessarily be clinically significant. All right, and the dose was subsequently increased to 70 milligrams subcutaneously. Michael comes back at, so I believe this dose is weekly in this case, yes, yes. Yes.
Sorry. So it seems like he was having symptoms, and I just think that you should note those, like the vaginal dryness and the periods. If those are problematic, we don't have to ignore, we should not ignore them ways to stop periods that are not just based on T. Vaginal dryness can and should be addressed if the patient wants that, and we have a lot of tools to do that, or some tools to do that. So I think I see a lot of people just kind of skipping past that because they're so focused on their T levels, but there's a lot of other tools.
Yeah, I
so
think-
excellent
I
talk.
think
So
actually
let's
that's
talk about
an
that.
important.
Yes.
Yeah, exactly.
Yes.
That's super important. In fact, actually, that's I think some of where we should be going with this. And so, because we're getting into a little bit of a box, because if I probably would have escalated the dose more quickly with the periods, all else being equal. Because I just want to get to goal already, and I'm mostly using testosterone as my agent. But we have a handful of things like the acne becoming more of a problem, which is like going to slow me down. And for me, this is a bit of a conversation. If it's just those two items, that becomes a little bit of a conversation with the patient. Which way do you want to err? Do you want to go a little more slowly to let and do some facial treatment, or a little more quickly and get rid of those periods? And what else was I going to say? And then in the vaginal dryness space, yeah, I think that's kind of an interesting space too, where we don't have a lot of data in terms of where we have like individual people have individual responses to their testosterone, and I don't know yet what it correlates with best. That is, some people have great lubrication, and some people have irritation, and I think there's some complexity there that we don't completely understand. Yeah.
Yeah. So, I mean, I think ultimately it's about the person in front of you. If having periods is really distressing, you need to take care of it. Yes, 1 in 5. I mean, there was an interesting article that was published in IJTH, I think 2020, that showed that about 1 in 5 trans masculine folk on T are still having their periods at 3 months. It goes down significantly by a year. It's like less than 5%. But the fact is that if you're doing this like slow increase, I mean, I don't do this slow increase in T, I'll just say. But if you're doing that and the person is having periods and this is not something they want, especially if they're, it's more likely if they're on gel, for example, than on injectable, you can have that conversation. And as you'll see in the reproductive health chapter, like thinking about other options, whether it's, long-acting injectable like progesterone, whether it's an IUD. I mean, there are other things that you can do. But yeah, if it's not an issue with the client, then you can just give it time.
And also, did you want to give us some thoughts? Because I think did Asa kind of cover it?
Sure. So I mean, if especially if they're a goal for their hormones, then I don't mess with the T anymore, and I just treat the period. So we have a lot of tools in gynecology. So all kinds of Depo-Provera, IUDs, implants, even surgical options, endometrial ablation, hysterectomies, etc. Like if their hormones are where they want them to be at goal. And then the vaginal dryness, I use topical estrogen formulations with a discussion with people that there's very low systemic doses, and it's a long conversation, and I have a lot of uptake when I have the discussion. I use a short course. This is extrapolated from cis postmenopausal women, but I use about 6 to 8 weeks, once or twice every 1 to 2 years, essentially. But it's nightly for 2 weeks and twice a week thereafter. And I've had incredible outcomes with people who have dysuria as well as vaginal dryness that's really related to vaginal atrophy.
And also the pelvic floor circumference.
Yes.
Yeah,
And then just to
Treat each piece as separate.
Yeah.
And you can attack these things for people independent of what's happening with their teeth.
Yes, and I'm not sure what your background is. I don't want to assume anything, but if you're not an OBGYN, do we have an OBGYN who would like to chime in? Oh, you are.
GYN.
Okay, perfect. Okay. Okay, great. Okay, thank you. Yeah, question in the back. Yes. Oh, thank you. Yeah.
Perfect. One over here.
Yes.
Oh, wait.
Yeah, question in the back. Yeah. Yeah, so that's an excellent question here. Yeah, so this is always something you need to know. So if a patient is on the short-acting esters, as Josh mentioned, you can check peaks, you can check troughs, or you can check mid-cycles. And so this is always the question that you always have to ask is when was your last injection? If you're checking it that day when they're in clinics so that you know how to interpret it. So I never routinely order the labs unless I verify that the patient has actually taken their medicine. So although I would say most of our patients are very compliant and adherent with their hormones, I do have a few that aren't. And I have one patient who, when she comes in to see me, has always forgotten to take her estrogen that day or the previous day, and I'm not going to check that blood level because it's going to come back low and not going to be helpful. So I tell her, okay, get back into the rhythm of it. Once you've been on this consistently for a week, swing by the labs, and then I'll give you a call with the result. Yes.
Stopping periods and they're not interested in progesterone. So I have some very lean trans guys. Their testosterone's in like the 600s, but their estrogen's in the 200s and 300s, estrogen too. And I'm from a reproductive endocrinology perspective, where is that coming from? Because I'm shutting the testosterone is in a range where it's not aromatizing. We're shutting down the hypothalamic pituitary axis. So where is that estrogen, that 200?
So I guess from an endocrine perspective, I'm not avoiding that those estrogens. I think that's not where my focus goes. And I don't really know that especially because you haven't checked LH and FSH, that you're even, how much.
No, I do.
And are you suppressing it?
No.
Well, okay.
So then if we go too high on the testosterone, then it starts aromatizing.
No, I don't. We don't have that. We did a little study when I was at BU, and that we're not there. There definitely is some aromatization, but that aromatization, as far as I can tell, is pretty much physiologic and within the quote unquote normal masculine range. That bugaboo that all those weightlifters are worrying about with their extra androgens is not something we're observing with the trans guys. That is, their estradiol levels decrease slowly, presumably relating to the fact that we're feeding back centrally and causing their ovarian production to be decreased, and the aromatization is less than what their original ovarian production was, and that's all we're seeing. Exactly.
The follow-up question is, I have also people who's not having periods who do still have persistent elevated estrogen, and then I'm wondering about concerns for unopposed estrogen. Like, are we concerned about endometrial hyperplasia if we have an estradiol in the 200s, the testosterone is therapeutic, and no periods and no progesterone?
So two things, and then so first to the one with the period, right? So I would even increase that testosterone dose because I would be trying to shut things down, and I would give them extra. And I am like your patient. I'm not big on prescribing progestogens, and but I'm not totally and in this narrow circumstance like just got described. But mostly I don't. Mostly I just bump that testosterone up. So and then to the wait, say the second piece again. Sorry. Oh, unopposed estrogens, and so two pieces to that. One of them is we were a little concerned historically in the theoretical, which is part of why, if you look at the old SOC guidelines, there's even talk about, and in the Netherlands and in Belgium, about doing hysterectomy by protocol to protect people from a cancer risk, trans masculine people from some cancer risk. And of course, they had no data on whether it was true or not because none of their trans masculine guys had uteruses because they took them all out. But what we have observed in the free-for-all that's over here in North America is that these trans guys heavily keeping their uteruses in place when we've looked at them, and it hasn't been done in the most systematic fashion, but when we do look at them, we're seeing atrophic tissue more like a postmenopausal circumstance. And but the point is that we're not.
If they're not bleeding, they're okay. The same we do with our cis women. If they're not bleeding, they're fine.
Right.
If they're bleeding, that's where you get concerned.
and I guess the point is that it's the bottom line is the function. So we're looking, it's endometrium. It's not the estrogen, and the estrogen, the assays are pretty fraught and pretty rudimentary. So we're not going by the estrogen level as an indicator of something concerning. It's endometrium specifically, and I'm telling you the history of the fear, and then in practice that not being what seems to be what's being observed.
Yes, question here in front.
So, I have some patients that I've been doing testosterone masculinization for them for 5, 6, up to 10 years since I've been doing this. And they still maintain a very feminizing estrogen level. And I cannot get those to go down. And their testosterones are in the 7, 8, 900s. They're not having periods, they're not bleeding. They are worried about those numbers. What are options, if any, that we can, and anastrozole doesn't work. I've tried managing weight, and that seems to have as big of an impact as anything. But what are other options to get those feminizing estrogen levels into the masculine ranges, if any?
Okay, so the question is, if I can summarize, is these persistently high estrogen levels, everything else is fine, and I guess where I would go is in the endocrine space, we're not focusing on a rudimentary assay that we don't even check in cis people typically anyway, and so we don't know what it means, and so that you're observing that there's a little bit of activity maybe in this person's fat or whatever is great, but it sounds like it's no harm physically to your patients, and it's not, and so therefore I'm saying to my patients what I'm saying to you, which is I am not going by that. I'm going by their testosterone level, and everything is good. They're not having their menstrual periods. They're not suffering from too much acne. Their testosterone levels are good. Their crit is safe. They are at goal. In cis people, we don't measure these levels. We don't measure them in cis masculine people. We have no clue. We see sometimes some overweight cis guys with some high estrogen levels, and we say, oh, you should lose some weight. Where I don't even know if we know that's true. But the point is, that's what we're doing in the cis world. And with regard to cis women, we're also not even using those estrogen levels as an indicator of estrogen status. If they've got a uterus and they're at a correct age, we're seeing if they're whether they menstruate or not, because we don't trust the blood test. And if they don't have a uterus or ovarian function, then we're measuring LH and FSH to see if it's through the roof and they're menopausal or not, because we don't trust the blood test. And so for those patients, I say all of what I'm saying to you so that they don't get too hung up on that blood test, because that's all it is.
So potentially even just stop checking them.
Yes. And I would not do an aromatase blocker. Exactly. Don't add extra medicine. I don't know their consequence. And Michael, I have to, when we're all done blabbing, I know there's a hand in the to our left.
All right, and I saw Asa's hand as well.
I just want,
There's no logic pattern is the bottom. Let me just start right out with that. So why would I introduce any risk at all to my patient achieving something achieving I don't know what? That's it right there. Their estradiol levels are already going down a little bit in what seems to be an appropriate way to the best of our knowledge, and that's it.
And Asa?
just to point something out that you mentioned, and I'm sure everyone is aware, the issue around hysterectomies in trans men in Europe was not because of a fear of cancer, but it was a legal requirement before people could have their gender legally recognized. And this actually happened until 2014, mandated sterilization of all trans people. It was an absolute human rights violation, and we should not be looking back at that as a way to, I don't know, support, anything currently. But I just...
Yeah, thank you. Thank you for that, because I'm focusing, I live in my little science blinder thing, but yeah, that's enormous, that's tears of bad here.
Yeah. Do we have a question on this side? Yes?
Yes, there is.
There's a yes from Asa. I think the Dutch even have a little data in that space, and certainly my own practice, I have a really hard time thinking of an instance where I could not get the periods to stop just by tweaking the testosterone up just a little further,
All right,
So,
so
I mean, if you want the, so Justine Dufresne, 2020, IJTH, article is there.
okay, so Michael actually does not come
Wait,
back.
I want to
Yeah,
observe.
oh,
Sorry, I'm just, it's the bladder police here. So okay, so it's 11, and we need, even though we're in the middle of a case, let's come back to the case after the break, and that's it. Great discussion. More to come.